Good morning. This topic actually was chosen not by me, by some other, because I think it's a rather difficult question, and I will show you in the next 20 minutes why. So these are my disclosures, and I also will talk a little bit about venetoclax. And I also will start with a case report. So we have a 44-year-old male with AL lambda, with a small plasma cell clone, immunofixation serum negative, in urine lambda positive, with a ratio FLC of 0.3 and a difference just of 40 milligram per liter. And as expected in the bone marrow, less than 5% of plasma cells with lambda in flow and histology. And with iFISH, we found translocation 1114 in 80% of the cells. The amyloid organ involvement was renal with stage 1 and cardiac with stage 2. And it was in rather good shape, so there was only a few symptoms, the Karnofsky index of 90%, and the past medical history was unremarkable. So this is one of the proposed models of primary events and clonal evolution for multiple myeloma. Of course, an entity which is much better studied as AL amyloidosis. And here you see that we are focusing on that. So on those primary events, in opposite to the secondary events, we have probably 2 or 3 groups as primary events, and this is hyperdiploidy and the non-hyperdiploid, which are mainly focused then on the translocations. And here you see the schedule of disease progression coming from ENGAS to smoldering myeloma, multiple myeloma, which requires treatment, and of course relapsed myeloma. So this is the model for myeloma. So actually, I think we should start to ask the question, should these cytogenetics testing be used for selecting initial therapy in multiple myeloma patients? And if you think about that, we also see it's not really easy. And I can just tell you what is in Germany is our politics about this. And I think this is always a big debate about it. So actually in Germany, we just say for high-risk patients defined by translocation 414 or deletion 17, we offer those patients a tandem high-dose treatment with autologous stem cell support. And we also offer the patients with deletion 17 a maintenance after this transplant. So it's not very sophisticated, I would say, for myeloma. But then coming back to AL amyloidosis. So we and other groups in the last 10, 15 years really studied hard the influence of iFISH cytogenetics on the biology and also on the disease and the prognosis. And just a couple of years ago, we really asked the questions, is our panel, our FISH panel, big enough and good enough to really cover all gains and losses we see in those patients? And so we studied together with our colleagues from the Genetics in Heidelberg a genome-wide copy number array and compared these results with iFISH. And here you see an overview about the gains and losses. And what was really expected was the gain of 1q1, and all the uneven chromosomes, and of course the lesion of 13, 15, and 17. And now we really correlated this with our probe, iFISH probe, and the concordance was actually close to 100%, so between 90 and 100%. So I really think with the iFISH, we cover most of the genetic aberrations in this disease. So it's really a reliable technique to characterize AL genetics. So coming to the clinical and basic data about iFISH cytogenetics in AL. First, I show our own data. So we can see that high sensitivity, we enrich the bone marrow, 40 ml bone marrow with CD138, and we get a high sensitivity for iFISH. So more than 90% of the patients really, we see an aberration. And this is translocation 1114 in half of the patients, or even more now. And this is associated with light chain only type, so the Benz-Jones type, another hallmark feature of AL. And in opposite to myeloma, we only see less than 10% the so-called high-risk cytogenetics. But we see in nearly 20% of the patients a gain of 1q21. And this is again associated with a higher plasma cell infiltration of the bone marrow and lambda light chain restriction. And finally, hyperdiploidy, also an opposite to myeloma, we only find in 10 to 15%. And this is now associated with kappa, with a higher plasma cell infiltration and a higher age at diagnosis and a heavy chain type. So actually, I would say that this is a more myeloma-like feature here. Our colleagues from the Mayo Clinic also did these kind of studies, and they also, with their assay, had a 90% sensitivity to really see some aberrations in these patients. And they also found that translocation 1114 is the hallmark and the most, the one with 40% seen in those patients. The trisomy, with a little kind of other definition that we used, was that they could show in 25%. And again, those patients were older at diagnosis, had also a kappa isotype and more DFLC and a higher plasma cell infiltration of the bone marrow at diagnosis. And as we did, they also looked how much was the overlap between translocation 1114 and the trisomies, and this only occurred in 4%, like we have shown as well. So I think pretty good validation of the previous data I have shown. So confirmation for the frequency of translocation 1114 and also the association of trisomies with age, kappa, and the clonal size. Next, we try to get a hint about clonal evolution using an oncogenic tree model, which is focused on the frequency of an aberration and a combination of aberrations in individual patients. And here you see the analysis of close to 700 patients with AL. So here is the root, and this is the likelihood for the branch coming next. And you actually here see, as we hoped for, two groups. So this is again the translocation 1114 group and the hyperdiploidy group. And when we did this for myeloma samples as well, we kind of saw the same thing, a branch for 1114, a branch for the hyperdiploidy. And then here's some high-risk features. Next, we wanted to know the intraclonal heterogeneity in these patients, if there's a difference between myeloma and AL amyloid. And here we looked for subclones in these patients, and a subclone was defined as a clone size below 2/3 of the largest clone we found in a patient, and an absolute difference of 30% to really be sure that we are dealing with subclones. And also what we did here in this analysis, we divided the AL patients group and the myeloma or the PC non-AL group in MGUS, smoldering myeloma, and multiple myeloma with standard definitions, because we know that we will see much more MGUS and smoldering myeloma-like patients in AL than we do in myeloma. So to cover this point as well. But still, you see, in each of this category, we have less subclones in AL than in myeloma. So has this something to do with AL and with the light chain protein, or has this something to do just with the biology of the plasma cell? We wanted to find out in that paper. So first we said subclones are less frequent in AL, regardless of the stage of the plasma cell dyscrasia. Then we checked each individual or some individual genetic aberrations, and here you see the figure for translocation 1114. And actually, those patients, they have always a main clone with this translocation. So it's very frequent as main clone. And this is true for AL amyloid, and this is true for the myeloma. So the opposite we found, or a slight opposite, for gain of 1q to 1 and deletion 17p13. There you see in red and green that we have also patients with subclones all over. And if you look for deletion 17, you even see that this is increasing if the stage of the plasma cell disorder is also increasing. So then we really wanted to know what are the main factors driving this development of subclones. And here you see a multivariable analysis taking into account of the disease, the underlying disease, high-risk clones, hyperdiploid clones, 1114, kappa versus lambda, and also if there's a heavy chain or not. And at the end, if it matters if the patient has amyloid or just myeloma. And at the end, you see that only translocation 1114, or this is the main driver which telling us if these patients got a subclone or not, regardless if they have myeloma or AL. So the conclusion here is the presence or absence of subclones are related to the cytogenetic aberration rather than the type of plasma cell dyscrasia. So, but now coming to the prognostic features, because that's what actually the title of the talk. So first, we analyzed the influence of translocation 1114 in patients treated first line with bortezomib. And first, we could show that there was an inferior remission rate in those patients with 1114 when they were treated with bortezomib, and this was a significant difference. And also, if we checked event-free survival and overall survival here, there was a difference, and we could also validate this in a small group treated with Cybor-D regarding event-free survival. And then next, we also made a multivariable analysis, and again, translocation 1114 was a negative factor regarding overall survival and hematological event-free survival. So for that, we can say translocation 1114 is an unfavorable independent prognostic factor in AL treated with bortezomib. Coming to the case report, we gave 2 cycles of Cybor-D. The side effects were transient gain of weight. Hematological response was good, was a low DFLC PR with less than 10 milligram per liter, and no organ response after 2 months. So we decided to give another 2 cycles, and the side effects were kind of the same, with in addition the nerve damage. And we got a hematological progression, so a rise of DFLC to 50, 59, and no organ progression, so it was kind of stable. So the question for the audience now would be, what should be the treatment strategy after cycle 4? Should it be starting second-line treatment with lenalidomide, continuing treatment with Cybor-D, considering ASCT, or stopping therapy? Oh. Oh, it's rather clear, I would say. So considering ASCT, and what did I put? No, it's not working. Oh, okay, this was also my answer, saying hello to Vaishali. Okay, so what are the data for translocation 1114 and high-dose chemotherapy? Again, we did the same kind of analysis, focusing on patients with transplant. First checked the CR rate in response to this treatment, and we saw that patients with 1114 had a higher percentage of CR after transplant, 40 to 20%. Next, we checked event-free survival and overall survival, and for event-free survival, there was this difference with 0.05, and in overall survival, there was this difference of 0.07. Checking again the multivariate analysis for event-free survival, we could see a very good hazard ratio of 0.5 as a prognostic favorable factor, translocation 1114, but for overall survival was the same hazard, but we missed the significance here, even after a follow-up of 17 months actually. So, but still, we would conclude T1114 is a favorable independent prognostic factor in AL patients treated with ASCT. And again, coming back to the Mayo Clinic results regarding overall survival, they also could show that patients treated with bortezomib and 1114 positive have a worse prognosis, and if they treat those patients with high-dose chemotherapy, there is no difference regarding overall survival. They also did a multivariate analysis regarding the Velcade-treated patients, and here again you find 1114 as a negative factor. So you also conclude this is a confirmation of previous data regarding translocation 1114 and bortezomib. Yeah, there's only few data around about high-risk cytogenetics. So here are a few Heidelberg data about deletion 17, translocation 1416, and translocation 414, just 13 patients. But if you see those patients when they are treated with bortezomib, there is a slight difference for event-free survival, and there was a big difference for overall survival. So we might conclude here that high-risk cytogenetics are not an unfavorable prognostic factor in AL patients treated with bortezomib. And due to the activity of Ray Comenso, we also did a multi-center analysis worldwide, just focusing on patients with AL amyloidosis and deletion 17. And as you see here in the retrospective study, the treatment was mostly based on Velcade, but there was also some high-dose patients. And 50% of the patients were rather sick, we have to say, but the response achieved with these kind of treatments was not bad, and the median follow-up was 30 months here. And these are the results, the Kaplan-Meier plots for overall survival with a median of 50 regarding overall survival. And the only prognostic feature we could find out here in those 44 patients was that a more complex karyotype combination, or if deletion 17 occurred in more than 50% of the cells, this was associated with a slightly worse prognosis. So, coming to the next case report again. So there was a decision for ASCT. We mobilized the stem cells with cyclophosphamide and collected 2 transplants, and did the transplant with a complication of fever and mucositis. And there was a good hematologic response, a CR with a ratio of 1, an organ response after 6 months with an NT-proBNP of 470 nanogram per liter, and an organ response for renal after 12 months with a decrease in proteinuria. So the question for the audience, the next question is, what should be the treatment strategy in patients with AL amyloidosis and translocation 1114? ASCT upfront. Treatment should be risk adapted, or CyBorD and transplant, or a tandem ASCT followed by maintenance with bortezomib. Oh. It's difficult, huh? So 4 is maybe not the winner, but 1 and 3. Okay. So my answer was treatment should be risk adapted. And why? Because this is kind of now the scheme we have if we want to treat patients with low risk or intermediate and high risk. And for the myeloma physicians, I always introduce these 3 comments here. So I say the low risk patients, they are treated almost like patients with myeloma. The intermediate risk, they are not treated as myeloma, and the high risk, actually, we don't know. And this risk assessment is mostly based on cardiac function. So, but where do we find here now results of IFISH cytogenetics? So we find them here in regarding the intermediate risk and BMDEX and CyBorD and actually MDEX as well. And it's not in that figure, so we modified it. We could also put it in here. So that would be my my overview about risk-adapted treatment in AL, and also including some features, some genetic features. So finally, coming to the future perspectives in patients with AL amyloidosis and also patients with 1114 translocation, we have a new drug there, it's venetoclax. It's an oral small molecule BCL2 inhibitor approved by the FDA for both CLL and AML, and it's currently studied in relapsed refractory myeloma patients harboring 1114 translocation. And there are already a few case reports of AL patients harboring this translocation. And just included here in this slide the first one, where venetoclax included a complete remission in a patient, which already was treated with Cybor-D, which you see here. And if you just focus on the DFLC, where it's going down, and then venetoclax, actually, it was switched to venetoclax, bortezomib dexa, stopped due to side effects, a little increase, and then this patient got venetoclax again, and DFLC was going into normal after 1 year. So this is the future perspective, but now coming to the summary in IFISH and AL amyloidosis. IFISH is a reliable technique to characterize the genetics of the plasma cell clone. I hope I convinced you about that. It tells us something about the biology. Translocation level 14 is the hallmark of the disease, and it's associated with bench-shown phenotype and lacks complex clonal landscape. Hyperdiploidy shows more multiple myeloma features, and the high-risk features are less common in AL. Regarding treatment, in translocation 11-14, positive patients, bortezomib is less effective, but the transplant at least overcomes its negative impact. So, but the question was, should cytogenetics testing be used to select initial therapy of AL? And I would say no, because risk-adapted therapy is most important to consider. Response in these patients can assess and should be assessed very early to see if the treatment delivered is really effective. And also other organ involvements should be considered, like the nerve damage, for example. But we could say, there is a but, it might be used for the consideration of ASCT, the timing of response assessment, earlier or later, maybe, and bortezomib in high-risk cytogenetic patients, and of course in the design of new combination therapies like the triple MDEX plus bortezomib, or including venetoclax. So these are my acknowledgements. I want to thank the whole clinic team in AL in Heidelberg, the genetic team there, and also the statistical team mentioned here. But of course, I also want to say thanks to all these international collaborators. I want to thank the genetic team in the Mayo Clinic, and I want to thank the ISA board, which is working hard together with the Spanish people to organize the next meeting there in Tarragona. And last but not least, also talking about international collaboration, I want to thank Marco Bassett, who joined us for 1 year as a guest physician from Pavia, coming in Heidelberg for this year, and he helped me a lot while doing this, working on this presentation. And also I want to thank the funding sources and the patients and their families. All patients analyzed here donated 40 to 80 ml bone marrow, and so I also have a big thank to the patients here. And now I say thank you for your attention.